It's my pleasure to introduce Dr. Ashwin Pakora to you. Dr. Pakora is going to be speaking about advances in understanding and treatment of addictive disorders today. Dr. Pakora is an associate professor of psychiatry and director of the Duke Addictions Program at Duke University Medical Center. He's a faculty member at DCRI, the world with global multi-site trial management capabilities, CRO, academic CRO. Dr. Pakora is a board certified with the American Board of Neurology and Psychiatry with subspecialty certification in addiction psychiatry and the American Society of Addiction Medicine certification in addiction medicine. Dr. Pakora has 20 years clinical and research experience with particular expertise in psychopharmacology and addiction issues. He's closely involved with several research projects designed to improve addiction treatments that are supported by the National Institute of Drug Abuse, the National Institute on Alcohol Abuse and Alcoholism, and the Substance Abuse and Mental Health Services Administration. Dr. Pakora has been a principal investigator on over 50 industry-supported Phase 2 to Phase 4 and post-marketing clinical trials in the area of alcohol and drug addiction, anxiety disorder, bipolar disorders, depression, pain disorders, sleep disorders, and schizophrenia. He is a consultant and/or serves on advisory boards for major pharmaceutical companies, and he has received numerous awards and honors, including the American Academy of Addiction Psychiatry Research Award, the Lilly Biological Psychiatry Fellowship Award, and the Indian American Psychiatric Association Academician of the Year Award. Dr. Pakora has published over 125 peer-reviewed articles and has given over 400 presentations and invited lectures at national and international meetings. He serves on the editorial board of 5 journals and is a reviewer for over 20 national and international journals. Dr. Pakora has served on NIH review committees and various committees at local and state government levels dealing with mental health and substance abuse issues. He is a member of the American Psychiatry Association, American Society of Addiction Medicine, American Academy of Addiction Psychiatry, American Medical Association, Indian Psychiatric Society, Royal College of Psychiatrists, and World Psychiatric Association. He is married with 2 children, enjoys, that's all in his spare time. And he enjoys working out in the gym. He does yoga, traveling, cricket. And I didn't know this. I've known Ashwin for a number of years now, and baseball. Please help me to welcome Dr. Ashwin Pakora. You're going to have a wonderful discussion.
Thanks, Peggy. Let me make sure you guys can hear me properly in the back. Okay. Well, thank you. The last 2 lines of what she said are the most valuable. You know, what you do with your family and what you do in your spare time. Other things are easy to do. So, you know, when you are supposed to talk about substance abuse and addiction, it's hard to get, it's hard to get a frame of reference of how much is enough. And that's a question I ask every patient I see who takes drugs. How much is enough? And nobody has been able to give me an answer. So, and that really is what, in a way, encompasses addiction, which is a loss of control. That basically, the way you distinguish between somebody who may use substances, and almost all of us use one substance or the other. Many of them are legal. I won't talk about the illegal ones. I'll talk about them in the lecture. But it's loss of control. And what I hope to demonstrate today is the lack of control or loss of control which occurs in addiction is because of what processes occur in your brain. It's not a moral choice or a moral weakness or anything else that occurs. It's primarily what goes on in your brain. And there are effective treatments available. We are doing a lot of research ourselves on newer treatments, but we'll cover a few points about what are the available treatments and what could be on the horizon. So I won't spend too much time on that. If you have been working at Duke for long enough, you know that you accept money from whoever gives you legally. right? So this is a more important disclosure, which is I do not belong to this society. We are in the business of treating people and making changes in their lives, hopefully for the better. So if you really want to advance your own understanding of anything, you just need to have a different perspective on things. It's not necessarily you have got to go there and chase after new information. As long as you can integrate some of the information which is out there into what you know, that's good. And the reason I say that is because it's estimated not even 1% of what is published is ever read. You know, you constantly hear about newer papers coming out and newer journals coming in the field, and the reality of that is it's impossible to keep track of this. So in some ways I like you know, giving lectures like this because it allows me to refresh some of the things which otherwise I might have forgotten. All right, so here's one thing which I want you guys to look at, and this is a PET scan of the brain in somebody who is in this case, a cocaine abuser, and comparing it with PET scan of the heart in somebody who's got chronic heart disease, congestive failure. And without going into too much details, you can see the changes. The right-hand side, the cocaine brain, essentially showing in the front, which is the frontal area, a decreased metabolism on the top. And similarly, at the bottom, you can see decreased metabolism in a heart disease patient. And this is just to draw comparisons of why you could look at addiction as really a brain disease. There are far more sophisticated changes that occur in the brain than this. But even with a gross PET scan, and in this case, the cocaine abusing person was abstinent, I believe, for about a month or so, you get these changes. And more importantly, these changes last for a long time. And I can't emphasize this point enough. The reason for that is people ask, well, how long should you treat somebody with addiction? You know, I saw a patient this week, was brought by the parents. The father is a physician, and patient is a senior at UNC, had a GPA of 4.0, was brought in after he had been injecting heroin about 6 bags a day for the last year and a half. And he was brought in, you know, also just tells you that it's not that substance use is easy to detect. Generally, the way substance use gets detected is some crisis occurs. And the way I define crisis in substance abuse is either experiencing or inflicting hurt. You know, that's what happens in substance abuse. That when people come to us, either they have hurt themselves in some ways, or they have hurt somebody else, or very often both. So he was brought in after essentially ran out of his supply and went into withdrawal, and actually tried to steal some things from home. So, and the question which was asked when he came by his father, who was a physician, is, well, how long do you think he needs to be treated? And my answer to him was, you know, he's a cardiologist. How long do you treat somebody with chronic hypertension? So the answer really is whatever it takes to make somebody better, and more importantly, to keep somebody better. So there are two aspects. One is getting somebody into recovery, which means you make that person stop using drugs. And the other more important part is relapse prevention. So in other words, making sure that person doesn't go back into using drugs. So and it's hard from the back to see it, but anyway, these are just pictures, and I'm not an expert in neuroradiology, and I don't expect many people to be. But if you look at what happens in the brain, on the top is somebody who's normal. So you always, whenever there is lit up areas, it kind of tells you that it's normal. And these are images of people who have been basically scanned after abstinence from amphetamine. So here is 4 weeks. You know, it's not come back to normal. Here's 6 months. It's not come back to normal. It's a year. Now it has started coming back somewhat to normal. It's 2 years. In this case, it's probably close to normal. So, and this is a person who has been abstinent. So you can definitely say that up to a year, well, 6 months for sure, there's gross deficiencies. Up to a year, there are still some deficiencies. The first one is what you want to look at here. this one. And probably by 2, you start getting things back to normal. And these patients, by the way, were scanned. We have a program here called TROSA, which stands for Triangle Residential Option for Substance Abusers, where people come and have to be resident there for 2 years. So basically, they're locked and are there, so we are sure they are not using drugs. So these were people there, person who came in, and when he graduated after 2 years. So around half of the people who graduate, we did a research study along with Wake Forest. This is not back to normal. So you know that they are already at a higher risk of relapse. And one of the research that's occurring is in areas like this, where if you can predict who is going to be at a higher risk of relapse. This is probably, again, a similar thing, that this is a cocaine abuser after 3 months. This is a normal brain, which shows very good metabolism in all parts of your brain. And look at what's happening in cocaine abuser, which is that your metabolism is simply not normal. And that is what's occurring in the brain when you expose it to drugs for a period of time. And that is a $1 million question, is how long does it take to produce these things? And the answer to that is it depends on the individual. If there are people who are at high risk, and by high risk I mean primarily genetic risk, and we'll cover some of that later, this can happen in a period of weeks. There are periods where people who are not at a higher risk, and in those cases it doesn't occur. So it's very hard to predict who is going to get addicted when they're first exposed to drugs. Not all people get addicted. As a matter of fact, most people don't. You have got tons of people who prescribe opioids for pain, and most of them never get addicted. Only a fraction do. And roughly the fraction is around 15 to 20% of people who experiment with cocaine get addicted. The percentage is even less for people who are exposed to opioids, so less than 10%. So majority of the people, and as you know, in alcohol it's the same. 95% of people don't become alcoholics; they just drink socially. So that risk is really genetic risk, and I'll cover that later. This is again a PET scan between normal and methamphetamine abuser, and here we measured primarily the dopamine densities. So in the brain, you have a chemical called dopamine, and if you don't have that chemical called dopamine, survival is impossible, because you cannot experience pleasure. And if you cannot experience pleasure, you would never learn things. Your learning is dependent on reinforcement or reward. That's how children learn, and my children exasperate me every time how tough it is to make them learn new things. But that's what it is, that dopamine is called the pleasure chemical. It's a normal chemical in the brain. And what happens with all drugs of abuse, and not just drugs, by the way, processes, the most popular lecture, by the way, I give very peggy, is sexual addiction and addictive disorder. We are doing quite a bit of work, and that place is always packed. So when I give that lecture, people don't want to listen to drugs. But there are processes which are also enjoyable. By the way, whenever you kind of eat or even watch TV, you get rise in dopamine. So this is a change which is showing that roughly the methamphetamine abusers in this study had half the number of dopamine transporters in the brain compared to normal. And this is why you get what we call a binge pattern of cocaine use. Because what happens is, this is the cocaine or methamphetamine abuser does not have enough dopamine receptors. So he cannot experience pleasure by normal stimulation, actually. So the only way you can experience pleasure is by seeking drugs which will try to raise this number here. And the way you try to do that is taking more and more cocaine. So most people who come to us with chronic cocaine, they are not high. They actually are dysphoric. They are feeling low in mood. They can't experience pleasure. And then they take more and more cocaine to get to that state. And so, and this is why it's so hard to treat somebody who has got cocaine addiction, because you haven't been able to develop drugs which can block dopamine to the extent that cocaine can't override the effect, which is what you do with other things. So this is what it is, that compromised dopamine system contribute to consequences of any kind of addiction process. And it takes a long time, like I mentioned. This is another slide of a methamphetamine abuser where we did PET scans. He has 2 years. This is a normal control. 2 years later, still don't get it back to normal. Again, emphasizing the fact that recovery is long-term. All right, so what is actually occurring in the brain when you get this switch, which I mentioned? So everybody starts using drugs voluntarily. And this is the point I want to emphasize where people say, is drug use a disease? So I say, well, drug use is not a disease. Addiction to drug is a disease. This process is always invariably environmental. The first time you choose to experiment with a drug, it depends on your personality and what goes on around you. As far as I know, there is not like a genetic factor which is going to force you, saying, you've got to go and try this. That almost entirely is dependent on people's personality traits of what they call sensation seeking. Some people are, we showed this in several studies, have these traits. So they are going to be more risk takers and more experimenters. And that's what happens there. And the second thing, of course, is what occurs around you, what social norms are, particularly in the peer group. Almost always, by the way, most psychiatric disorders occur in adolescence and early adulthood, almost all. The only exceptions, of course, as you know, are the dementias and the postpartum disorders. That's all. Everybody, schizophrenia, bipolar disorder, depression, first onset before the age of 22. And same with addiction. So the switch is what leads to compulsive use. And the way you get that switch is because of two things. One is learning and memory. And the second is what happens in the brain in terms of cellular adaptations. And I've covered a bit about what cellular adaptations occur in the brain in terms of these changes in the dopamine system and some of the other systems. Let's talk about learning and memory, because this is worth understanding if you want to understand why a drug habit becomes tenacious. Okay? So the brain circuitry is exactly what's involved in eating and sex and sleep and those sorts of things. But why memories become important is, this is a study some of my colleagues did at Duke, where basically you expose people who are addicted to a neutral stimulus. And neutral stimulus basically is a picture of, say, Yellowstone, or a nice beach picture. They're very relaxing, typically relaxing pictures. And you show cocaine, and you can see the moment you show a cocaine video, your craving is off the chart. Neutral stimuli will not induce any craving. And you can actually see it. You can change the video pictures in a matter of seconds, and you can see the difference. So you can actually have somebody looking at a scene on a beach, or a video on a beach, and suddenly instill something to do with a cocaine house. You don't even need to show a cocaine video. You just show like a crack house, and you will find craving induction occurring. And this is what happens. Your amygdala gets activated. So what starts happening in people who are addicted to drugs is a powerful conditioning system comes into play. A good example of that is, you must have heard of Pavlov and his experiment of ringing the bell and making a dog salivate. So almost the same thing occurs, but imagine that magnified 100,000 times. So the person gets habituated to the environment and emotional states which make them use, and that becomes the conditioning cue. So in the dog experiment, it was the bell. In the cocaine experiment, there are thousands. It would be when somebody gets angry or upset or good, they use cocaine. So that's the emotional state that gets attached. The place where they use, if they're using it in a house or in a car, that gets attached. So all of them start lighting up the amygdala. Amygdala is where your primarily learning processes start. So your brain has learned to associate certain events, what we call neutral events, as triggers to use. And it becomes a very difficult process to extinguish these triggers. I mean, because there are not one or two, there are a lot, and often the patient doesn't understand. And that's why some of the really intractable addicts have to come and stay in a place for 2 years to extinguish this. The only way to extinguish this is not to expose the brain to the drug. So, that's the same philosophy on which AA works. The AA philosophy, one day at a time, what they are really saying is don't expose your brain to alcohol one day at a time, but still live in the environment which you used to be exposed to alcohol cues. So over a period of time, an extinction occurs. So you no longer, in Pavlov's experiment, it took him like less than 7 days to extinguish the cue between ringing the bell and salivation. Okay. So he has another interesting experiment which was done. So like sexual activity is considered to be an arousing activity for the brain. So normally people would say sexual activity is enjoyable, and it would be against a lot of natural, certainly propagation of species kind of experiments to say that it isn't. But anyway, so normally when you show an erotic video to volunteers, there'll be some arousal. Okay. So this was a study done where there was controls and cocaine users, and you showed them an erotic video, which is this yellow, or a cocaine cue, which in this case was basically a crack pipe and some paraphernalia. So this is what happens in normal people. There is no arousal whatsoever with the cocaine cue, but you got the normal arousal with the erotic video. Exactly the opposite occurs in cocaine. So you can see with cocaine people, there was actually hardly any arousal in the inferior frontal gyrus, some arousal, but clearly cocaine had taken over. So with food, you can't even do this experiment, because with food you kind of get absolutely zero arousal in cocaine folks. So what essentially has happened is that the drug stimuli have taken over all normal stimuli. And when you talk to patients, they say, well, like I saw a patient, he's a professor, and very happily married, has had a long-standing history of cocaine addiction. One of the most difficult patients I treat, and he was doing well. He really had tragedy. His own daughter died of heroin overdose in college. So he had all motivations. He was doing his best. He drives 2 hours to come and see me. And after a period of about 2 years, he was doing well, and I was seeing him, and he relapsed. And he relapsed, and by the time we knew of it, I knew of it when his wife called me. I was actually in India early in the year, and she called me, and I'd missed seeing him a few times, saying, he came once. I found he was coming in the house in the morning at 5 o'clock through a window. And when those kinds of things occur, somebody's taking drugs. And she said, I immediately drug tested him. One of the things you do, which I do when I treat patients, is there is a random drug testing set at home. So the wife or husband or whoever is testing the person at home at least weekly. So it's important, because that kind of keeps them, gives them a structure. She said, I tested him immediately and he was negative. So then I called her over, and then we did a hair sample. One of the good things about technology is that you can find out if somebody is using drugs. And I tell that to the patient, that if it's impossible to cheat with a trained professional. Urine drug screens you can fake, hair samples you can't fake. So when we first did the study of hair sampling, this was years ago, I was in Philadelphia. So we said, okay, we are going to start doing hair testing. And I ran a big cocaine program. And the point was, this was a research study. So I said, look, it's not going to affect you guys either coming to program or not coming to program. This is strictly a research study we are going to do. And they were being urine tested. So we were going to start in a couple of days. And immediately after that, everybody had like a Michael Jordan haircut. So you could actually make out who was using or who isn't. But coming back to this patient, so we did hair sampling, and it turned out positive. And for about 6 or 8 months, he was, substituting urines. Not only that, he had, taken such enormous risks. And this included fraud at work, where he was a very respected professor, to obtain money and other things. And his wife said, I can't understand why he's throwing away his life. Not just life, but his respectability. He's a very respected member of the community. And the reason is this, that drugs take over. So drug seeking becomes primary. And it's important to distinguish drug seeking behavior from a person. So a person can be very respectable and in some ways almost understand what he's going through. But the drugs will be driving that. I mean, just imagine, and there was an experiment done about how long would starvation induce primitive behavior. It's a classic experiment which was done in the 60s. I forget the name of the psychologist, but it is. So they took UCLA or Stanford professors and put them in a room and induced starvation. Okay, so we're not going to give you food. And you just sit around and relax, and you can talk in a civilized manner. And they had to stop the experiment within like 36 hours. Where people started fighting, became aggressive, so to obtain food. I mean, it was regression to primitive mechanisms for survival. And so exactly the same thing occurs, just magnified several thousand times. And that's what is called motivational toxicity. In other words, the primary motivation for your existence becomes obtaining drugs, and it becomes compulsive drug use. So it really is a brain disease which is expressed as a compulsive disorder. I mean, that's what addiction is. And treating it is the challenging part. So I just showed you how complex the slide is. I must tell you, I don't remember a word of it, even after remembering it 20 times. But there are at least 8 or 10 different neurotransmitter systems in the brain which are involved. So it's more complex. You know, people say, well, why can't you just develop a drug to treat cocaine? And I must have tested more than 100 drugs myself personally over the last 15 years, and you haven't been able to develop it. The people who are a lot smarter than me, who are doing it for a longer period, is because of this complex way which drugs affect multiple systems. And so genetics are important. You know, when I give talks at schools and other places, so this is a common thing which is asked all the time. You know, what is the role of genetics? So the one thing to know is that if you're susceptible to a disease, doesn't mean you're going to get it. So you can carry a genetic risk factor for alcoholism. I probably have a risk factor for alcoholism. My uncle died of alcoholism when he was in his late 30s. I'm not dependent. I can drink socially, and I don't think it's very, very unlikely that I would be dependent now. I've crossed the age where you develop dependence. So it's almost sure more than one gene is involved. So in addiction, at least as far as I know, you are not going to see a genetic therapy in our lifetime. It's not possible. The environmental heritability estimates are 40 to 60%. So in other words, if you do twin studies of people who are identical, it's not that 100% of twins would become alcoholic or addicts if one of them is. It's only 40 to 60%. So environment plays around 40% role, 40 to 50. So they are equally important. And the etiology is usually several factors. So it's similar really to a disease like hypertension, where you've got diet involved, family risk factors, lifestyle issues. It's the same with addiction, that you've got the psychological issues primarily have to do with other illnesses like depression or bipolar disorder, or what's called traumas. So PTSDs, one of the biggest studies which is going is returning veterans from Iraq, where they are developing really high rates of alcoholism and substance abuse associated with PTSD. So this is what happens when you carry a gene. So all genes express proteins. That's what genes do, and that's how genes determine color of your hair, color of your skin, or color of your eyes. So it's an expression of protein. So sometimes the protein which is expressed is different. And we did a study to show that with a gene called serotonin transporter in cocaine addicts, to show that the expression of the serotonin transporter protein was abnormal. So you could actually have a different regulation of the serotonin system in the brain. The other way it occurs is it affects enzymes, such as this enzyme, which is the aldehyde dehydrogenase gene in alcohol. So talking about gene therapy, I mean, I probably was incorrect in saying that we won't see it in the horizon, but Japanese folks, they have a variant in this gene, aldehyde dehydrogenase gene, which makes them almost extraordinarily susceptible to alcohol effects. It's called the oriental flush. So you drink a glass, not even a glass, a sip, and you become unpleasant. And the best way I can describe it is that variant of the gene prevents metabolism of acetaldehyde into water. So normally when you drink alcohol, it gets metabolized into acetaldehyde, it gets metabolized from acetaldehyde into water and acetyl coenzyme A. So you accumulate acetaldehyde. If you get acetaldehyde in the body, it's extremely unpleasant. That's what we do by treating people with antabuse. So if you have antabuse in your system, you cannot drink. I had a patient last weekend who really disturbed me on my fishing trip when I was at the beach. Called me 5 times, then called the alcohol poisoning center, who eventually contacted me. So she was on antabuse, and she had gone for a barbecue. And I had warned her specifically that if you go for any kind of barbecues or any restaurants, to confirm that what you're eating does not have any sauces made out of alcohol or vinegar. Vinegar is an alcohol product, and of course she didn't, and then she threw up for about 8 hours. So that's the reason. If you carry that gene, you cannot develop alcoholism. So in Japan, they have done studies to show that the rate of alcoholism in people who carry that gene is 0%. Okay, you can't get any better than that. So unfortunately, that gene variant occurs in less than 5% of people here. So it doesn't really matter that much because it's a recessive gene. So when you intermarry and somebody has a dominant gene, even in Japan, it's changing. I mean, now, not even 25% carry both copies of the gene. Or it can affect sensitivity to alcohol. So, one of the ways where you can actually judge is if your son or daughter comes and says, hey, I have no problems with alcohol. I drank, 8 cans the other day and had no effect. And that's the worst thing you want to hear, because that means that their sensitivity is less. And if sensitivity is less, or other words, you have an innate tolerance, you are more likely to become an alcoholic, because you can do the math, right? So if you don't get an effect with 8, you're likely to drink 18. So you already started consuming huge amounts and started making changes. So the test which actually people do is you get people in and you ask them to drink, and you calculate body sway and see how much drinks you need to start slight swaying. I mean, it's very, very subtle. And the more drinks you need to have body sway, the more risk you are actually of having alcoholism. So treatment is not just, giving you a brain transplant. So that's not what the treatment is about. So you've got to reverse these processes. And these reversal of these processes, like I told you, include preventing exposure to the drug. And that you do by giving medications, and that you do by doing what's called behavioral treatments. So there are there are various treatments available. The biggest obstacle I have seen in my life to applying all these research-based findings is this. Is that, the manuals are so tightly wrapped with plastic you can't open them. So people don't even bother about knowing what's out there in terms of evidence-based treatments. So if you go on the internet and look at various kinds of treatments available, you'll see there are people giving hydrotherapy and all kinds of things which have no basis in evidence but are yet popularized, and people love that. So, but the fact is that what we develop with our research treatments may not work because of real life issues in terms of what's possible, what's funded, or reimbursed. So that's why you need evidence-based treatments, and this is a good example for you. So, so here's your tax dollars and my tax dollars at work, there was enormous amount of money spent on youth anti-drug campaign, billions of dollars, and eventually the General Accounting Office concluded it was not effective. It wasn't effective. You don't need to kind of spend $1 billion. You can do it by going to a street corner in Durham or in Cary or Raleigh, or to schools and knowing what happens. I mean, there hasn't been any change there. So the smartest way, by the way, I learn about what happens in addictions is not by reading the DEA reports or anything else, epidemiology, but simply talking to some of our patients. They know exactly the dynamics of how much the value of cocaine on the street is or heroin on the street is, and that tells me a lot more than what I hear at NIH or everybody else, whether or not drug use is going down or up. So, just to tell you, by the way, that I read about the budget for this year, and there's been an increase in that funding. So including with the current administration. So just tells you that where often it's not necessary that something has to work to get funded. Here's another thing which I think is more concerning, which is pharmaceutical marketing and what its effects are. So there's a drug called Neurontin, which many people might have heard of, particularly in neurology, where the drug was approved only to treat epilepsy, actually. Yet 90% of the prescriptions were written by psychiatrists who did not know a word about epilepsy. So it is basically treating psychiatric conditions like bipolar disorder and alcohol and drug treatment. And eventually, Pfizer had to pay close to half, or $500 million in damages. All right, so what does research have to say about effective treatments? So first, intervene early. Okay. The earlier you intervene, the better your chances are. And it's hard to say how you're going to intervene early. So we are doing big projects in primary healthcare clinics, for example, to have screening tools where you can ask people to screen. And these are voluntary self-reports, and these have been standardized. So there is, for example, a screening tool called AUDIT, or Alcohol Use Disorder Identification Test, where you have 3 questions, and the chances are 80% that you can detect early unhealthy or harmful alcohol use. So there are early intervention includes detection and then having brief treatment. So there is a protocol called, which we are studying, as Thomas knows and others in CTN, called screening and brief intervention, where you do 1 or 2 sessions of motivated treatments, and that has an effect better than not doing anything. So there is this misperception because of some of the things which I said about treatment of addiction, that treatment needs to be long term. And that is true. Treatment needs to be long term in people who are addicted to drugs or substances. But if somebody you catch early on, when they are in that phase between progressing beyond experimentation but not yet reached addiction, which is what you want to catch them at, even brief interventions can be effective. And mostly it's in the case of alcohol, less so in the case of drugs, probably for marijuana to some extent. The other drugs, that escalation is very rapid. So you are unlikely to catch somebody with heroin, for example, who is using heroin in an not experimentally but not yet addictively. You start using heroin and within weeks you are using it almost every day. So for sustained recovery you need at least 3 months, but usually 1 year. So and the reason for that is, again, what I said, that's the length of time it needs for the brain takes to reverse some of the processes. Those receptor changes and other things I mentioned, they are at the end of the day proteins. A receptor is manufactured and it's recycled. So after 3 months, your body manufactures a new receptor. So if a receptor is abnormal, it's like your red blood cell. It's abnormal, it's abnormal. It's going to take another 120 days for the bone marrow to produce new ones. So that's what happens. So ideally about 12 months. Here's something which is intuitive, which is the more the treatment, the better it works. So exposure to more intensive treatment is better for people who are intensely addicted. And having some kind of a leverage is actually good. Okay, so there was a feeling initially that people have to come by themselves to get their addiction treated. If their parents or family members force them or the courts force them, their motivation is not as good. And research has shown that that's not the case. And clinically also I can tell you that's not the case. Doesn't matter who gets them into treatment and what threats you use, that's fine. Because how you think when you're under the influence of drugs is a lot different than what you would think when your brain is not exposed to drugs. So we have people who have been brought literally kicking and screaming, kids by their parents into treatment. And once they have been through the treatment, within a matter of weeks, they will change. Their thinking changes. So it's always good to get people into treatment, no matter how. And there was a study, again, we did in our clinical trials network, which shows that it's called providing incentives work in treatment. So rewarding people actually works. And the better social supports you have, the better it is. So here's the incentive and reward mechanism. So this is an interesting story about to what extent drug use is involuntary. Okay. So the most effective behavioral treatment to treat addiction is what's called motivational incentives. So in other words, you tell patients every time you come, I'm going to give you a voucher, which you can go and exchange at Walmart for $5 worth of items. Okay. And you say, God, I mean, why do we need psychiatrists and psychologists? Just have a deal with Walmart where you give $5 vouchers to patients and they'll be fine. So so it's more complex than that. What happens is in a drug-taking person's lifestyle, the priorities in terms of what they want to do are wake up late, okay, use drugs late in the night, wake up late, after that have cigarettes, coffee, food, figure out how you're going to get the money to take that day's drug or next day's, figure out how you're going to avoid people you owe money to, and then figure out whether or not you're going to have the time to go and see people who are treating you. Okay. So this is the pattern which happens in their brain, and that's just simply how drugs take over your functioning. So getting yourself into treatment is not a priority because of all these other things which have occurred. So what your reinforcement is doing is making that a priority. You're saying that, hey, you're going to get $5 if you show there. So immediately say, well, maybe I won't, go and have my Big Mac. Let me show up for treatment and get $5. And once they come into treatment, you have the option of doing what you want to do. So it's simply a way of engaging and getting them into treatment. And how you recover from drug use is not like a linear recovery or a smooth recovery. It never occurs in any diseases. So you have stabilization, you have got some recovery, then you probably have some relapses and some rehabilitation and then maintenance. So it's always, I mean, this graph is also not like this. It's probably like this, like this. So to give you a perspective, so if you have what's called an intensive outpatient treatment program, which is a 3-month treatment program, outpatient, which is a commonly used outpatient program for addictions, 50% would complete it. 50% won't. So 50% completed, not recover, just attend. Most of the people don't even attend, and that you would say, well, that's really lousy. I mean, you're having this program, and 45% of people don't even complete it. But the thing is that if you don't have that program, if you leave drug addiction to itself, not even 5% would do it. So it's 9 times more. So that's the way you kind of evaluate risk or benefit. So what are the medications? I know that probably I'm going to have another 10 minutes to finish. I'm not going to bore you with all details about medications, simply to tell you about there are medications which are available out there. And so there's a whole list. I'm not going to go into every. Anyway, for drugs, yeah. Yeah, but I want to kind of talk about interesting things rather than just talk about medications. Medication names and things, you can look it up, and I'm just going to tell you something. So here's what you should know. So for drugs, all drug dependencies, it includes, cocaine, marijuana, you name it, heroin, you have 3 drugs approved. For alcohol, you have 4 drugs approved. And for nicotine, which probably is it here? Let me see. You also have 4. So for legal drugs, you have more treatments approved than illegal drugs. And that's the way, unfortunately, the field is. That, and by the way, all three drugs are approved for opioid dependence. All right? So there's no treatment for marijuana or cocaine or amphetamines or methamphetamines or phencyclidine or your ecstasy or whatnot. There is a huge deal. I mean, the good example of this, to put it in perspective, was when the HIV epidemic hit, and the cocaine epidemic hit. The cost of cocaine use, during that epidemic to the society was far, far more than the HIV. Yet see where we are today in terms of what the treatment for HIV is, and see where we are today in terms of where the treatment for cocaine is. And it's not an easy task. So for opioid addiction, there's a drug called methadone, which is used to treat. You cannot prescribe methadone for treating opioid addiction in practices. You're going to go to what's called methadone clinics. And there are all kinds of issues about giving methadone. Primarily the issue is that it's a harm reduction approach. In other words, once you start using methadone, you're going to be on methadone for a long, long time, in many cases lifelong. So some people argue that's simply replacing one addiction with another. And in some ways it's true. You're making somebody use a drug, but it's a harm reduction approach, which is that you're not going and using heroin and sharing needles and spreading HIV or hepatitis C. And there is the risk of overdose with methadone. So we at Duke have not started a methadone clinic. I personally I'm not in favor of it. So this is a better drug, which is Suboxone or buprenorphine, and which is the way field is going. It's far better than methadone, particularly because of this, which is it's very hard to overdose on this drug because it's a partial agonist. So there's a safety margin, and the second is it's not as euphoric. So with methadone, what happens? You start at 30 milligrams, in a year you are at 120. So your use goes up. With Suboxone, you start at one dose, and the dose is going to remain the same after a year, or if not less. Naltrexone is an antagonist. So the way the first two drugs work is that they go and block the same receptors which heroin or OxyContin would block. So if you use heroin or OxyContin, on top of that, you're not going to have any effect. And you're not going to have the craving because they block the effects. So naltrexone works exactly the opposite. It blocks these drugs, but it produces no euphoria. In other words, there is no stimulation of these drugs, receptors. And that's what the opioid addicts don't like. So they need some degree. Remember I told you about some pleasure. So they need some stimulation of the system. So naltrexone they never take. So if you do studies at 9 months, not even 5% are taking naltrexone. So hardly anybody uses this. The only way patients we use this for are impaired health professionals. So impaired health professionals who are referred to as doctors, nurses, pharmacists, they come from their licensing board. So I mean there is a strong deterrent that if they relapse, then they lose their livelihood really. So that's where it works, but otherwise it doesn't. So no approved treatment for stimulant dependence. Some other drugs which are being studied are drugs like Provigil and Topiramate and others, which may or may not show promise. We will see. I'm not too optimistic about any of these drugs. We are involved in some of these trials. Alcohol withdrawal I'm going to skip. So for alcohol dependence, there are 3 drugs approved. One is naltrexone, one is Antabuse, one is Campral or acamprosate. And naltrexone is approved both oral as well as injection. And the best evidence so far about what drug works is Antabuse. If you have Antabuse, there is 100% you can't drink. The trouble with giving Antabuse is patients don't want to take it. So the way you can give Antabuse, all my patients on Antabuse are on supervised Antabuse. So in other words, either somebody who is a reliable person in the family supervises it, or we supervise it. They come. I mean, some patients have to drop in twice a week to my office to take the Antabuse in front of the office manager, and sometimes in front of the counselors. Otherwise, they don't. In the absence of using Antabuse, the best drug to use is naltrexone and this injection called Vivitrol, which came out. So you give an injection once a month, and I have several patients who are on it. The way naltrexone works, and this is interesting, is when you drink, what happens in people who are alcoholics is that the first drink will actually prime the brain for the second drink, and the third drink, and the fourth drink. So actually that's what distinguishes really an alcoholic from somebody else. That generally is the amount of heavy drinking people do. Not drinking 1 or 2 drinks or 3 drinks. It's drinking 6 or 8 drinks frequently. So naltrexone cuts that effect out by blocking opiates. Because what happens, you drink alcohol and you stimulate the opiate system, and that stimulates the dopamine system. So if you block that, people will go and maybe have a couple of drinks, and then, I mean, that's what patients report. They say, we don't feel like we should have another drink. Now, they may still drink heavily because of social pressures. And that's different. That's what happens in colleges, with binge drinking and others, that it's largely a social context, not what occurs in your brain. So that's how naltrexone acts. When we did this study, I was in Philadelphia, and I knew this drug works. It was first approved to treat opioids, and then people just said, let's try it in alcohol. when we were doing the study, there was a bar next to our facility, and the guy came in, and we used to go there sometimes. He said, "Doc, you're killing my business." I said, "What's going on?" He said, "These patients are coming in, and we kind of rely on our business on the heavy drinkers. They come and, drink, have 6 drinks, and now they come, they have 1 or 2, and then they just sit around and smoke and spend time, and we don't see any money." So that's when I knew, when those kinds of things, that the drug works. So this probably is a drug which it hasn't caught on because psychiatrists don't like to give injections. So many people feel that, well, we shouldn't touch the patients. But I have had good results with the drug. So Campral is another drug which was developed in Europe years and years ago and reached the market here. Unfortunately, it works in a very different way, which is it affects a system in the brain called the glutamate system. But the studies have shown, there's a large study done by NIAAA called the Combine study, which compared all drugs and all behavioral treatments and showed that naltrexone was the best and really Campral wasn't as good. And that has been my clinical experience. So although it's approved, I don't use it at the first line, and most of the people won't. So antabuse we have covered. There are some anti-epileptic drugs which have been studied. The best one is Topamax or topiramate, which acts again on the glutamate system. And actually that drug was effective in controlling heavy drinking. And we use it off-label because it's not approved. The drug has become generic, so the company is not going to file for approval. So this is smoking cessation therapies, which also has been an interest of mine. So you've got several kinds of nicotine replacements, patches and lozenges and inhalers and spray and Wellbutrin, and then a drug called Chantix or Varenicline, which probably is the most effective drug out there in terms of smoking cessation. The only issue with Chantix is in a proportion of patients it can produce side effects. So about 30% of patients will get vivid dreams in particular and nausea. So that can be an issue. But otherwise it's a partial agonist. It acts exactly the same way as buprenorphine or Suboxone does. So here's a thing. Why do people feel that sometimes treatment doesn't work? And the reason is because if you look at one single episode of care, it will never work. It's a bit like how perfect is a sugar control in a diabetic. It's never perfect. If you see at their sugar readings or from the day-to-day basis, it will fluctuate. But if you look overall, whether or not there's improvement, look at multiple episodes, then treatments work. And detoxification alone is not treatment. So if somebody comes and, okay, well, I want to get off drugs. Getting people off drugs is not the hard part. Getting people off drugs, I just need to admit them at Duke or somewhere else. And within a week, they're off drugs. The issue becomes when they come back into community of relapse prevention. So how are they not going to relapse? And that's why the focus really should be long-term management, which is relapse prevention. And Tom McClellan did this study just to show that relapse rates with adequate treatment are comparable in addiction, diabetes, hypertension, and asthma. They're, this should be high, by the way. So it's around, depending on how you define relapse, which is change from normal, as long as there's effective treatment, they're pretty good. The people who I mentioned to you, by the way, about 40–50% of people who don't show up who in our outpatient program, that doesn't mean there's no treatment for them. All we do is we shift them from an outpatient approach into a residential approach. So you match severity of illness with severity of treatments. So there are some brief treatments, behavioral treatments which are effective. The brief intervention I mentioned, there's another one called motivation enhancement therapy, which is also effective. And I was talking to one of our junior doctors today about what motivational enhancement therapy means. So give you an example, and I'll take smoking as an example. So if a patient comes to us for saying they're smoking, and you detect they're smoking, and you ask them, do you want to quit? And the person says no. Okay, so most doctors or people would stop right there, or give some kind of a message which is confrontational. Smoking is bad for your health and blah 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 blah, which they've heard it hundreds of times, so they will tune off immediately. So the way you kind of reframe it is to get the patient to think about it. So the patient said, no, I don't want to quit smoking. So I said, that's all right. Do you know anybody in your life who has quit smoking? If you have a really resistant patient, you might say, I don't know a single person in my life who has quit smoking. And in that case, you may say, well, let me tell you somebody who has quit smoking, who I know, maybe my brother or sister. Now, can you tell me what could be the reasons why somebody quit smoking? So in other words, you take it from being a personal issue to an issue which is outside and get the person to think. And the person may then say, well, I think that person may have quit smoking for health reasons or something else. And that gets somebody to think about it. So for the next time when the person comes, or the next, maybe in 3 months or 4 months, 6 months, when you readdress it, they may say, okay, let me give it a try. So that's what's called motivational engagement. So it's a strategy where you try to create doubts in the mind of a person and see whether it works or not. So these are all the evidence-based treatments. This will shift now acamprosate. So brief intervention, motivation enhancement, family therapy, all these things I mentioned, they work. What doesn't work, which is actually important to know, is so simple education. There is not much evidence unless it's targeted and unless it's accompanied by continuous education. So it's like CME programs for all of us. If there's one CME program, I know for a fact I wouldn't remember anything. So you have to have it rehearse and rehearse. And education has to be active, not passive. So one of my pet peeves is if you get a DWI, the court will just tell you, go and have passive education, pay $100, $200 or whatever it is and go and sit in a room and watch a video. And you watch that for whatever number of times and you get your license back. That's completely ineffective because that's passive. And no, I don't think there's a single study which shows that's effective. Confrontation doesn't work. So, and this is very hard to explain in terms of family dynamics because there's so much emotion involved when somebody is in a family that the tendency is because, if you get hurt, you become angry, and that's a common equation. So people kind of respond with anger, but that generally doesn't work. Your anger is not going to be effective in changing the hold drug has taken over somebody. So what probably it will end up doing is creating a lot of other complications. Relaxation and other things make people feel good but have very little effect directly on the brain. So there's a big study done on acupuncture, so it helped in certain cases with mood but not with quitting drugs. And then of course you have other, there's a study now which is being done of exercise, and I'll be curious to see what the effects of exercise are. So far the effects have shown that exercise will make you be healthy and certainly improve your mood, but will not allow you to stop using drugs. So I'll be very curious to see what happens with this study. And I think that's probably about it. I mean, we have some time for discussion, and I'll talk about some clinical vignettes. But I think this is what probably is going to be the future, what's called translational research, which we have. There's a big research institute, at Duke, as you know, the CTSA, where if you know the mechanisms, the better, more you understand mechanisms, the more you can develop treatments. So that's where we are putting in a couple of proposals based on some of the understandings we have had from animals to see what we can do about treatments. And just to tell you that there's a lot of work out there. So look at the number of drugs which are being tested. So these are the conclusions, which is it's a brain disease. We have genetic, developmental, and environmental factors. Combination of medications and behavioral treatments work best, and effective treatments should be long-term. And having learned all these things, I'm going to ask questions right now to all of you to see how much you have really learned. But seriously speaking, even if something you take home, it's better than having, not enough information. So last is probably the most important acknowledgement. I learn more from my patients than doing research, and I'll be honest about that after having been in this field for 20 years. And that's why I think it's very important for researchers to be seeing patients. If they don't, their findings are going to be biased. People who participate in research trials are very different, and they come with a different motivation than real life situation. And I think you learn a lot and actually take back those questions, what you learn from research. And that's how actually many or most rather, advances in psychiatry occurred by serendipity. It's not that somebody developed a medication to treat depression. There was some smart clinician who observed giving MO inhibitors to somebody who had TB, was improving the TB patient's mood, and say, hey, let's go and see what this medication does. And that's how antidepressants came in the market. That's how lithium was developed, just that clinician observing. So it's what you observe as a smart clinician which often leads you on the right track. Well, thank you for listening so kindly, and I'll be happy to take any questions or answer any questions you have. Yeah, please, go ahead.
Have you seen a higher percentage of drug addiction in persons that have attention deficit disorders?
Yes, there is a answer is yes. So there is a link. I mean, I didn't cover all the comorbid disorders. So there are certain psychiatric disorders which increase your risk. So the highest risk is with bipolar disorder, which is 9 times. So if you have a bipolar disorder, average risk increases 9 times. Lifetime risk is around over 50%. Attention deficit disorder increases your risk between 3 to 4 times. Okay. Schizophrenia increases your risk by around 5.5 times. And depression and PTSD increase your risk by around 2 to 3 times. So most of the major psychiatric disorders are a big contributor. It's very, very unlikely when somebody comes in a chronic stage of addiction that they won't have a psychiatric disorder. It may be something which is caused by the drugs or which may be there before, but usually they have some comorbid conditions. So your answer is, the more interesting answer about ADHD, which again there are studies going on, is ADHD increases the risk of developing substance use, but treating ADHD does not appear to reduce your substance use. Okay, so that's worth knowing. And there were at least 2 studies done, including studies done in our CTN, which showed that giving ADHD drugs will be effective for ADHD, but have little effect on substance abuse.
You showed some slides on the PET scans after patients are addicted. Are there any cohort trials that have shown, following a cohort of patients or people to see what their PET scans were like a priori?
Even before the treatment was started?
No, before they became, I guess, addicted.
Oh yeah, that's a great question. So the answer to that is that study has just started in Singapore. There haven't been any studies here. So what you say, which is developmental epidemiological studies or cohort studies, it's a very important thing to study about risk factors. So you can't do it in states for all kinds of reasons, because you can't have a standardized way of screening people. You can only do it in places like Singapore or Israel or places which have drafts. The place where you can catch adults. Remember I told you that most addiction starts in like adulthood, or like adolescence and early adulthood. So Singapore has a draft where at 16 everybody has to volunteer and they are assessed. So then at that stage you can say, well, I'm going to look at your genes and PET scans and then follow them up. And from age 16 to 25, the chances are some are going to get that develop and some don't. Then you compare the differences. But that's a good question. So one thing I'd like to mention along those lines, which I didn't have time to cover, okay, so it's about marijuana use and risk of psychosis. So, there's a whole debate, and, we can spend 1 hour debating about marijuana and what it does and what it doesn't do. So there is increasing evidence now that marijuana use increases risk of psychosis in patients who are vulnerable. There are at least 4 large studies done. So if you are carrying a risk for schizophrenia or bipolar disorder, and if you start using marijuana in your adolescence, the chances you're going to have that precipitation are high. They're higher than 5 times actually. And there was a study 2 studies out of Scandinavia, 1 out of Israel and 1 out of New Zealand. So that is something which, in patients with psychiatric disorders, marijuana use has problems. And there is the research and the debate is about, how much marijuana is acceptable in these patients, and all those are debatable points. But that's one thing about marijuana which has been shown to be really effective. Yes.
on the radio about the epidemic heroin addiction in Afghanistan and people dealing with the war and so forth that way, and how many really young children, 7, 8, 9 years old, are becoming addicted because it's what their parents have to offer them for treatment. And going back to the PET scans, what's it like if someone becomes addicted pre-pubertal age? Do they recover faster, less well?
Yeah, so heroin use is increasing, by the way, for all kinds of reasons. So we are seeing certainly, younger kids are getting addicted. I just saw somebody who is 16-year-old girl who heavily addicted. We did a study here about a few years ago on adolescent opioid addiction, looking at the drug called Suboxone. So, and that was published in JAMA. So the best treatment for adolescents who are addicted to heroin is Suboxone. How long they need to take it? So I'm just telling from clinical experience, the study stopped at 1 year, so we don't have more than 1 year data, but I've been following those patients up, and about 80% of those patients who we recruited are still in treatment and doing well as long as they're on Suboxone. The people who stopped almost all relapsed. There are a few people who could stop it. So in other words, the answer is that adolescent opioid addiction treatment more or less resembles adult opioid addiction treatment. It's going to be long term, even if it's a short addiction history. And that's what the field is saying. I mean, there isn't too much data apart from this one study that was done, but more and more people are believing the same. The short addiction history does not mean that they need shorter treatments. Yes?
You mentioned that people don't like taking antabuse. Why is that?
Because of the hope many people have who have been dependent on alcohol, that at some point they would like to socially drink, or what's called controlled drink. So that's the simple way, that people do not want to be in a situation that tomorrow at my son's or brother's or father's birthday or any kind of festive events, I can't even have a sip of wine. So because alcohol has been a pleasurable effect on the brain, that otherwise they wouldn't be drinking so much. So it's very hard for them to accept that, and they may accept it in the beginning. I feel very rarely people don't say, I'm not going to take antabuse. They say, oh yes, doc, I'll take antabuse, of course. But what you find is that they're telling you they're taking it when they're not. And that's what happens. All compliance with drugs is not about patients coming and telling doctors. When we teach our medical students, say, if you want to find about compliance, you don't ask patient, are you taking your drug or medication? They'll always say yes. You just ask them in a matter of fact manner, whether are you comfortable with your medicines? And you just see their response. And if their response is ambivalent, then you're almost sure they're not taking medications. So that's the reason. Yes?
I've got a quick question. Are you finding it harder when you're treating alcoholics that they tend to come to you with the information that now alcohol on a moderate base on a daily level has now been shown to be good for the heart and good for preventing dementia?
Yeah, that's a great question. So I get those things all the time. Okay, not particularly from people who are heavily alcoholics, but from people who have not reached that stage yet. So the alcohol's effect, I mean, all of you know that, drinking in moderation, and moderate drinking is defined as less than 3 drinks a day, has reduced the risk of coronary artery disease, and as you say, Alzheimer's. So the issue becomes what % of alcoholics can return to controlled drinking. Okay. For majority of the person, that's not an issue. Tomorrow, if you're already drinking in that range and you haven't had any problems, nobody's going to say change it. The issue becomes somebody who has escalated their drinking, can they go back? And previously it was believed that an alcoholic cannot ever have controlled drinking. So once you become an alcoholic, and now the latest study, I think I don't know if some of you were here when Dr. T.K. Lee gave his talk, but he gave a talk and he reviewed the study called the NESARC study, the National Epidemiological Survey on Alcohol and Alcohol-related Conditions, where they showed about 20% of people actually returned to controlled drinking. I mean, that is self-report. I mean, unless the patients were lying, I don't know. But in that large epidemiological cohort, 20% returned to controlled drinking. The trouble is when, and how. So the way you do it is, I have a patient. He's he heads a big law firm here. Has been, very productive. He was referred to be by his internist because he was having increased LFTs and some degree of hepatitis. And he has been drinking around 10 to 12 scotches, single malt scotch a night every day for the last several years. Okay, he doesn't drink during the day. He has had no impairments and not a single DWI, nothing. But he and his wife, I mean, from 6 to really 11 o'clock or 10 onwards, I mean, they basically drink 2 to 3 drinks an hour. And then he sleeps, and his body has developed tolerance. So his only effect, I mean, his dependence was that, nothing else. And he said, I want to really drink 3 drinks a day. And he's a very bright guy. I like, single malt myself. I drink single malt scotch. I don't drink 12 drinks a night, but I do drink. So we debated, and I said, okay, your strategy is, so we started him on actually Vivitrol, which reduces heavy drinking. So now he has come back to 4 drinks a day. His LFTs are back to normal. The moment you come from 12 to 4, that's 1/4 reduction. And so in his case, we are going to see if he can maintain, and we have agreed that if he can maintain at less than 3 drinks a day, then I have no issue with it, because there's no other he's not stealing the money. His wife, actually, I interviewed her. She came and met me. She said, no, he's fine. He's not like falling over or having some problems. So if he can do 2 or 3 drinks, that's fine. So some cases you can't do it. So it's not a black and white situation. I don't know if that's answered your question, but that probably is what the field is at. Yeah.
Have doctors in your field...
Oh,
only 12 drinks. Sorry. Have doctors in your field generalized their understandings of drugs and alcohol and applied it to sugar addiction by any chance?
Sugar addiction?
Yeah.
No, I don't think so. I think the whole area of food addiction is only being researched recently. Okay, so process addictions, what you call gambling or shoplifting and sex and food, it's only been recently developed. I don't know, we have a system called the DSM system for diagnosing psychiatric disorders, so it's being updated now. Depending on Dr. Volkow is the director of NIDA. She's been pushing for food addiction as a part of that. If it comes in, I think it's unlikely that it's going to be sugar addiction. I think it's going to be probably encompassing a large variety of carbohydrate containing foods. But yeah, I mean, it's, one of the things which I do is screen people for bariatric surgery who are referred to me. And it's amazing how loss of control over food in their lives resembles loss of control over drugs. And one of the last patients I saw, I mean, we can't even weigh these people because they're so heavy. They have to be weighed in a loading dock. I mean, the guy, he can't move. Yet he's, there is a big program here called Structure House. I don't know if you're aware of it. It's a residential treatment for people who are obese. And the people, smuggle cell phones in and call pizza delivery people and bribe them to get food through windows. I mean, all exactly the same what you do with drugs. So yeah, I think in certain percent of people, I think that thing happens. It's more shown for gambling though. And certainly it's being shown more and more for sex, that the discontrol gets severe.
Thank you.
Well, if there aren't any more questions, Thomas.
So my question, Ashwin, is: have there been any studies to show the link between children of addicts of, like, say drugs, alcohol, cocaine, etc., where those children are addicted to things that have less impact on their lives, but they're still addictions, like, say, shopping or sex or...
Yeah. Well, the answer is no. In other words, there hasn't been research done to see if children of addicted individuals are at an increased risk for non-substance related addictions. As you may know, the children of, say, alcoholics are at 4 times higher risk of developing alcoholism. So the genetic risk is high. But what you call other addictions, because there wasn't any awareness of it, and it's very hard to do pedigree studies. It's for reasons which have to do with primarily that drugs are not legal. So it's hard to do those studies. But I can tell you from clinical experience that we have seen substitution. A patient I treat, she actually is the therapist herself. So when I saw her, she came for prescription narcotics addiction, prescription pills. In her earlier life, and this was before I saw her, she was bulimic. She got over that. And then I treated her. And she got over that. She started doing therapy again. She started drinking heavily. Got her over drinking, and then she started shoplifting in a very, very dangerous situation, which is she lives in a community. Her husband is a president of a bank. Everybody knows her, and she was shoplifting at a Harry Streeter where she shops and people know her, where there are video cameras and things which are completely unnecessary for her and which financially wasn't even an issue. And the only reason she got away, that they didn't charge us, was because people knew who she was. So so eventually we managed to get that under control. And then she started having affairs or flings, which were uncharacteristic of her. And as a therapist, it was very traumatic for her because she understands psychology. So you see symptom substitution occurring. It happens all the time in AA meetings, right? You go to AA meetings, you can't walk in before inhaling smoke. So here are people who are stop alcohol, are smoking like chimneys, and probably going to die from nicotine addiction. And actually the biggest mortality risk factor in substance abusers is not drugs, but nicotine and alcohol. There was a big study done which was published in JAMA where they showed the outcome of people treated for drug addictions. They die of alcohol or nicotine. Well, thank you for listening so patiently. I hope it has been of some entertainment.